Good evening, everyone, and thank you very much for having me. I wanted to thank Dr. Corinne Schuster-Wallace. I'm trying to see where she's in the back row, for inviting me to be here this evening. It's my real pleasure to be here, actually, and I realize that you're all coming from different perspectives this evening, and that's pretty exciting for me. As we've mentioned just now, I've really had the opportunity to work in many different countries around the world, doing both disaster response work as well as development work. And tonight I'm going to predominantly focus actually I'm going to talk about both. I'm going to focus on Indonesia, Aceh, Indonesia, what happened after the tsunami, and then I'm going to go on to actually talk about what's happening now in terms of the projects that we've been working on. I had the opportunity when I started working with the Red Cross to work in Rwanda in a post-genocide situation. That was my first experience working like this, a huge eye-opener. I was very green at the time, I have to admit. And from that, I've had lots of different opportunities. I was in Aceh after the tsunami and the big earthquake that preceded the tsunami. I was in Pakistan after the earthquake. And then in terms of natural disasters, I was in Haiti again after the earthquake, and then I went back to Haiti with the cholera epidemic that happened. So with that experience, I actually had the opportunity to go to work on my sabbatical with the World Health Organization. The group within the World Health Organization is called the Health Action and Crisis Team, and that's the team that actually focuses on looking at disasters and looking at the epidemiology, the prevention, as well as the response, and from the humanitarian perspective. So if I think about my goal for this evening, what I'm trying to do actually is I'm going to give you some examples of what it's really like to work in the field. You know, we hear about it, we see these disasters happening, we see a bit on the media, but it's really interesting to try to figure out, well, what is it like? I have people asking me all the time, well, what's it like when you actually get there, and what does it feel like, and what do you do? So I'm going to try to give you a bit of a taste of that, focusing on the Aceh experience. Now, this particular lecture series is intended to give us insight into various challenges around the world, and so I hope that this just gives you an insight in terms of the challenges of disaster and humanitarian response. I will focus on Aceh, as I mentioned, and I will talk about the collaboration that we have now between McMaster University, Shakwala University, as well as the Rotary clubs, including the Rotary clubs of Dundas, if any of you are familiar with any of the local Dundas groups. The one thing that I was going to say, I don't know if anybody's had the opportunity to travel in airports recently, but I feel like I'm in airports a lot. And the HSBC Bank has some really neat advertisements around right now. I don't know, has anybody seen those? I see a few. Yeah, I love those advertisements. And they have these pictures, and they have a picture with a caption with one word. And then you walk a little bit, and then you see the same picture with a different caption, meaning the exact opposite. And they talk about perspectives and different perspectives. So I made one up just for this evening, thinking about water. So this is my own doing, so it's not very good. Bear with me. So if I were to look at these two pictures and I say, okay, on the left-hand side, which is actually in Aceh, Indonesia, and these are you can see the fishermen's boats there, very, very calm. So if I was actually a surfer, I would look at this and think, that's terrible. That's not good surfing weather on the left. But on the right, oh wow, those waves look great. But if I actually turn that around and think, no, I'm a weather specialist, and I know about climate change, and I'm actually knowing the implications of this, I might turn that completely around and say, no, I like the picture on the left, not the one on the right. And the reason I'm showing you this tonight is just to say that I'm telling you my perspective from my experiences. And certainly you'll meet many different people who do humanitarian response work and have very, very different perspectives. And that's why it's exciting for me to actually talk to people from different sort of walks of life and people who have very different experiences than my own, because I find that I learn a lot from talking to other people as well. So what I'm going to do is I'm actually going to start with a story. I've told this story before, and I don't know if any of you have heard of it before, but it's a story from a colleague of mine and a friend who I met right after the tsunami. And it's his story, it's his real story about what happened to him and his family after the tsunami. And it's really trying to get you into the mindset of what some of these natural disasters can do to people. So here's his story. I call it Dee Dees Story of Hope. Dr. Lynda, do you believe in God? I do. I'd like to share my story with you before you leave. It was 8 o'clock in the morning on Sunday, December the 26th, 2004. And my 2-year-old daughter, my wife, and I were already awake. We were talking and relaxing when all of a sudden my house began to shake very heavily. We ran outside into the streets like everyone else. Some of the houses were falling down. Some people were really screaming. The earthquake was like none I'd ever felt before. We have a lot of earthquakes, but this one was really strong. We were really scared. It went on what seems like for hours, but it was only a few minutes, and then it finally stopped. And after it stopped, we were all afraid to go back into our houses for fear of the houses falling down. About 20 minutes later, when we were still trying to help the people that had been injured in the earthquake, there was a loud, a deafening sound. And we looked up, and a huge wall of water was coming straight for us. I grabbed my daughter, and I grabbed my wife. That was the last time I ever saw them. The next thing I knew, I was floating in the water, high above the trees and houses, gasping for my next breath. I grabbed onto some sort of a floating object. I think it was maybe a kitchen cabinet. 4 kilometers later, I washed up on a mountain. I spent 3 days on the mountain eating coconuts and drinking coconut milk. 3 days later, through all the debris and dead bodies, I had to go back and I had to find my family. I walked, and after many days, I found my wife's body, my parents' bodies, my siblings' bodies, and my in-laws' bodies. But I never did find the body of my 2-year-old princess. My house was gone, my business was gone, and my life was gone. But I believe it wasn't my time to go. I believe that I'm going to see my family again one day, but for now, I must keep going. I need to rebuild my life again. There is hope, and we need to rebuild. So that was Dee Dees Story. And that's the reality of many people who live through these situations. In 2011, the Center for Research in Epidemiology and Disasters said that we had about 332 natural disasters, over 30,000 people dead, and much higher, 244 million people affected at a cost of about $366 billion US dollars. If we think about natural disasters, most of them we don't even hear about. I've actually just put this slide up just to tell you about what's happening in the past 6 weeks. And I would be interested to know actually how many of these have we really heard about, because almost none of them ever hit the mainstream media. If it does, it's a very quick thing and it continues on. But just to say that natural disasters are happening all of the time, all around the world. And a lot of times the response is a local response, so we don't necessarily hear about that. But it's certainly happening in just the typhoon in southeast China that happened as of recently as yesterday. So if we think about who in the world is actually affected by disasters, and we took a map of the world, and we actually shrunk it down and expanded it up depending on who's affected, it would look something like this. And in fact, if you look at this, you see that Asia looks huge. And that's the case. The case is that Asia actually has the highest number of natural disasters in the world. And also because of the dense population in some of those countries, those are the countries that are actually most affected in terms of the number of people affected. This is actually a photo of post-earthquake Pakistan, and this is just one example of what it might look like when you have people who are internally displaced. You'll see that the conditions look very, very basic. And in the back, you can see one of the tents is a UNHCR, which is the United Nations High Commission for Refugee, who donated some of the tents in this particular setting. We know that the number of disasters reported is increasing, specifically natural disasters. And if we look at the numbers, this is what it looks like. And it's not just a reporting bias. We actually know that the numbers are indeed increasing. We can think again about why is that happening, and certainly climate change. And I'm not going to talk really about climate change tonight, but certainly we need to be thinking about the effects of climate change and why we're starting to see what we see now. And we have different kinds of disasters, but certainly the kinds of disasters that I'm going to mostly focus on are the natural disasters. Although we know right now that there's lots of other disasters happening, complex humanitarian situations. For example, in Syria, I had some conversations with colleagues in Ottawa last week about the situation in Syria on the ground, and it's worse than we're hearing even in the media. It's incredible. Again, for this particular talk, I'm going to focus on the Aceh experience, which was actually a combination, because it was actually an area of conflict for 30 years prior to the tsunami. So there were some major security issues that we had when we were there as well. And why is this important? Well, when I think about earthquakes or any kind of natural disaster, I think the most important thing to remember is that they completely disrupt infrastructure in all different sectors. So in fact, what you have is you have people that are, that most people that are affected by disasters live in low-income countries, and the people within those contexts that are most affected are the most vulnerable and usually the most poor. And one example certainly is in Katrina, and we can think of what happened in Katrina. People who have access and who have resources can get out of those environments if they're not immediately killed during for example, an earthquake. Usually you can get out of that situation if you have means to do so. But I remember and hearing a lot of colleagues talking about what happened, for example, with Katrina in the US, and it was the people who left behind, who were the people who were either elderly, who were poor, who were physically unable or mentally unable to leave. And that's the situation that I see all of the time, that it's really the people that are the most vulnerable that are most affected in these kinds of situations. And therefore what happens is the countries that get pummeled over and over and over again, it's really hard to develop over time if they have another disaster. And the disasters might not be a huge, big earthquake. It might be a little bit more flooding here, a little bit more damage here, a little bit here. But what happens is it spirals them down into a very difficult situation where it's very hard to increase the level of development again. I ran into this quote, and I just love it because I think it summarizes that nicely, from Oxfam 2005. Disasters are profoundly discriminatory, even those that are considered natural. And factors that were there before the disaster, such as poor social conditions, mean that these people in the disaster zone will be more affected than others. So if we say, okay, we hear that there's a big international humanitarian issue, and how does Canada respond? There's different ways that we as a country respond to these kinds of situations. Certainly one of the things that we often will do is respond in a military sense. We can have a discussion about that and whether you actually believe that the military should be doing, quote, humanitarian work, and in fact, is it an oxymoron? In fact, can military be doing humanitarian, because they're never seen as neutral and non-biased. But the reality is that we do have military that often go into these situations, and as humanitarian workers, even working with organizations like the Red Cross, we actually have to work with the military beside us. So how to figure out how to do that and how to keep the dynamics as neutral as you can without seeing like you're taking a side. So in Canada, the other thing we have that I've been more involved with is the Canadian Red Cross. So the Canadian Red Cross has what we call an emergency response unit. And what that is that it is a rapid deployment hospital and basic health unit. Now, we've been training healthcare workers and broader people to respond to disasters for a long time, but specifically for the ERU training since 2007. And then as of 2011, we actually now have capacity in Canada to send out a rapid deployment hospital as well as basic health unit. And the thing that's different about these now is that actually it's modular. So it can be modified depending on the need of the situation. What happened before this is we actually would work with the other Red Crosses around the world, particularly the Norwegian Red Cross is a big partner, still continues to be, the German Red Cross, the Finnish Red Cross. But right now, Canada actually has capacity to actually do it on our own if we needed and wanted to do that. So the team that's deployed right now in Syria, they've set up a hospital in conjunction with some of those other Red Crosses. There's 4 Red Crosses involved in that one now. They've actually set it up in Jordan, across where a lot of the refugees are coming across the border right now. I'll tell you that these pictures, actually, the one on the top left-hand side is a picture of the ERU tent hospital when it gets set up. The one on the right-hand side is some of the healthcare providers actually going through the kits and pulling out equipment. And the bottom one is just a picture of the logistics. There's a huge amount of equipment that needs to be transferred and moved in a short period of time. So these are small boxes, but when you get the big crates with all the tents and everything, it's pretty impressive actually what can be moved in a short period of time. These actually sit in a hangar right in Mississauga, right by the airport. So if it needs to go, it can go actually pretty quickly. And we have people trained to be able to get up and go within 24 hours to do that too. So if I focus now on Aceh Indonesia, I'm just going to lead you to this reference actually that was just published 3 weeks ago by the World Health Organization. It's actually quite an interesting one if you're interested in learning more about it. It's called Tsunami 2004, Comprehensive Analysis. And what it actually is they've taken all of the information they've done post-tsunami qualitative interviewing. They've taken as much data as they can and actually focused in the different countries that were affected by this tsunami and actually sort of put together lessons learned and that sort of thing. And they actually go through different areas. They go through public health, medical care, water sanitation, shelter, clothing, food and nutrition, everything down, engineering, communication, all the way down. So it's actually quite an interesting read if you have any particular interest in this area. So what I'm going to do is just tell you a little bit about where Indonesia is, because many of us who aren't involved there don't really know where Indonesia is. So if I take a world map and I actually look up to find Asia, and then Australia's not labeled down there, but it's on the bottom right-hand part of our slide there. And then you'll see a whole bunch of islands in between there. And in fact, if I zoom in, many of those islands are actually part of Indonesia. Indonesia has 17,000 islands and has about 700 current languages. So you can imagine the challenge of trying to coordinate something like that. They do have one national language called Bahasa Indonesia. So that's the language that people would learn if they go to school. Important to know, actually, Banda Aceh, so actually if you look to the top left-hand corner, in the very, very top, you'll see a city called Banda Aceh, and that's the city that was completely wiped out by the tsunami that happened in 2004. And that's the one we're going to be focusing on as I go through this. A couple things before. Aceh was under conflict for 30 years before the tsunami. It was around, there was a free Aceh movement. Achenese people often say that they feel quite different in many ways than a lot of the other areas of Indonesia, so they were actually fighting for a free Aceh movement. As a result of the conflict that was happening there, and as we know, conflict significantly affects infrastructure in many different ways, including things like access to safe water, sanitation, and basic health needs. Before the tsunami, just interesting to think about this, only 48% of people in the entire province had access to clean water. 29% had access to toilets. Vaccination rates for measles was only about 31%, which is a big problem when you're talking about displaced populations with low immunization rates for measles, because measles are the things that will kill kids very quickly who are undernourished in this situation. The polio immunization rates were only 7%. And if we look at how many women were dying as a cause of pregnancy, it was 373 per 10,000 as opposed to 4 in Canada. So really significant numbers. So you can imagine if you have those kind of problems before and have this, you can imagine what you're up against. 167,000 people died that day in this province. This is a photo of a truck, if you can make it out, on the side on top of a house. These are the scenes that I actually saw when I first came in. And this is the good part, actually. Some of the areas we couldn't even access because the roads were all gone. Now, this is an important one to look at because this is a picture after about 3 or 4 weeks. You're actually seeing the hospital, the major referral teaching hospital. This is what it was at about week 4. This is after they had tried to go through it and get all the bodies that they could find. But this is actually a good picture 3 or 4 weeks after. But this is the reality of why the hospital was absolutely, completely not functional during this period of time, and why it was important for international aid to actually try to fill some, at least temporary gaps. One of the things that happened when I first arrived in Indonesia was, I remember we got to the field hospital, which is tense. We put our bags down, and I turned around ready to start working, and the team leader said to us, no, hold on a minute, we're going back out in the car. I thought, what are we just got? What are you talking about? He said, you have to actually go, and he said, you can't see a lot because the roads are down. He said, but if you actually go out, I want you to actually go out and see as much as you can see. And this is the pictures that I was taking that day. Because he said, you can't understand the context of where you're working if you don't actually try to get a sense of what's going on. And we were supposed to go out for 3 hours. After an hour, I said, I've seen enough. It's just absolute devastation. There were bodies still everywhere. And I was there at week 3. So at that point, it was still enough to say, okay. So that, in fact, these are the kinds of pictures that we were seeing, and this is towards the end of this tour when we were looking around. And this is somebody just took a picture of me sitting. But one of the things I have to say that's a real challenge when working in this environment is the ethical challenges that we face. Every single day, almost every context is really challenging from the ethical perspective. We often have to, like, you have an oxygen tank and you're trying to think, okay, if you're treating certain numbers of patients, you know that this gentleman right now really needs this oxygen, but you also know that the chance of having younger children coming in soon is very high, and that how do you decide who gets the oxygen? I had quite a conversation with a colleague who lives in Syria, and he just came in for this meeting about a week ago in Ottawa, and his challenge was in August, after the chemical weapons attack, he had to decide who he was going to try to save. There were thousands of people that were dying. And he had to sort of make a decision, how am I going to try to triage this situation? And he said it was horrible, because there's different schools of thought. One is, you know what, you go to try to save the people that are going to have an effect on the community. So, you know, try to save the healthcare workers, because they're the ones who actually can help others. Or, no, there's another school of thought thinking, no, you got to save the children, because they're the ones who are going to live the longest, and they're the ones who, you know, you need to try. And there's no right answer to that. But he struggled with it, and he just decided that he was going to try to save as many children as he could. And he did that. There's not much he could have really done, but some more supportive measures. So he tried as best as he could, and of course most people still died. And he was really struggling with that about, should I make the right decision? Should I have tried someone else? You know, and those are the kinds of things that we actually do have to deal with on a daily basis. I know that when I see patients here, patients die in these situations that I know in Canada would never die. And it's really hard to understand that and actually to feel okay with that. And you never really feel okay with that, but you have to put it back in the context of where you are. So these are certainly some of the issues that we come into contact with. And because of the work that I do, in fact, Dr. Alicia Schwartz, who's one of our ethicists and chair of ethics here at McMaster, actually, has become a great colleague of mine, and we've been working with a group of researchers now around the ethics of humanitarian healthcare and humanitarian work. And there's been lots of different studies and offshoots that are happening with that. The website is humanitarianhealthcareethics.ca. But that one actually has some interesting case studies, some papers that have been written specifically around the ethics of this kind of work. So if you're interested in that, certainly that's a resource to go to. So once we got back to the hospital, this is what it looked like. So the tent hospital it's amazing what you can actually do in the hospital under a tent. I actually would have never appreciated what it was actually like. So in fact, in this picture, what you're seeing, the building in the back is not the hospital, but all the tents are the hospital. So we actually had an operating room, a recovery room, very minor intensive care unit, a labor and delivery ward, and then the pediatric ward, women's ward, and men's ward, like that. We actually had access to a plain film x-ray, and we actually had a very basic lab that would do probably two different things. So it is really trying to manage, you know, the situation and knowing that you don't have most resources that you would here in Canada. I'm going to take a step back here, and that's what it looks from a distance. Now, the building you're actually seeing in the back is actually a stadium. It's a soccer stadium. It was built just before the tsunami, and everyone was very proud of it because in many parts of the world, soccer is a big sport. The challenge that we had with this, though, is it was severely damaged during the earthquake. So, in fact, what had happened once the structural engineers came out and actually assessed the situation, they actually told us that you have to move the hospital. It's too close, and we had lots and lots of aftershocks and lots of earthquakes afterwards, and they said, you know what, it's not safe enough to stay this close. So, in fact, we actually had to pull everything down and move it over further away from. So that was quite an interesting experience. What you can't see in the picture actually is over to the right. There's a helicopter landing pad where we actually had communication with some other facilities in the area to be able to transfer patients in and out as well. The one thing, though, that we do as humanitarian workers face all of the time is issues around security. And even if you're working in an area where it's been a natural disaster, where it's relatively stable before the disaster, when people don't have food and water, they panic. That's just the nature of, I think, humankind. And I've seen lots of riots and things in peaceful places, but security is always an issue. So as aid workers, we're actually very trained for security. I can't tell you how many security courses I've done. We always have things like, there's always curfews, there's always strict rules about how you go, where you're allowed to go, who you can go with. There are rules about knowing how to do checkpoints, for example, checkpoints and how to manage checkpoints in certain circumstances. I've learned how to check for landmines and how do you drive around landmines. There's all sorts of things that obviously you wouldn't normally do here, but But depending on the context of where you're going, security is a big, big issue. And even in this hospital, there was a question, because there was conflict when we arrived. And it wasn't for about a year until the peace accord was signed that made a significant difference to the ability to develop. But even in this hospital, we had different parties, different sides as patients. And we had to be very careful about how close they were to each other and who was talking to who. And we have the Red Cross is very, very strict about no arms. So in fact, if people had arms, they had to disarm before they came into the premises, all those kinds of things. So there's lots of issues around security. And unfortunately, we have had colleagues die. We had maybe from some of you remember, in Chechnya, there was a Red Cross Canadian nurse who was actually assassinated in Chechnya in her sleep one day, and nobody ever took any, what's the word I'm looking for, any responsibility. That's a good word, thank you, responsibility for that. So, I mean, it happens a lot that there are issues around security, and we have to be really careful around that. I had an issue in Haiti where I had to transfer a baby who actually probably would have died if I hadn't transferred them to a facility in Port-au-Prince, in the capital. And it was a big decision on the team as to whether we could even do that because of security. And in fact, I went past curfew, and that was a big issue. And then I went through an area that aid workers had been kidnapped before. So it's not the same decisions that, here in Canada we make the decisions based on the current situation and the patient, and you don't have to think about all those other extraneous things. But in these circumstances, there are so many other factors which influence our decision making. So I'm going to take you into the hospital. This is what it looks like inside. It's a tent. Again, it's pretty amazing what you can do in a tent. So what you're seeing here is the top picture is actually ward rounds, lots of orthopedic injuries because of the earthquake. And then the bottom one is I call it a small little intensive care unit, although it's very, very basic intensive care. This gentleman actually had fallen out of a coconut tree because he had no food for his family, and he was trying to get coconuts, and he fell out, had a major head injury. And unfortunately, he didn't make it. We thought he might, actually, because he turned around quite nicely, and then we lost him. But in these circumstances, some of the things that we saw after the tsunami were things like really odd pneumonias. A lot of people had near drowning experiences where they breathed in and breathed in this horrible tsunami water, very, very dirty, and had these pneumonias that we would call tsunami lung because we weren't sure what was causing the infection. And it wasn't until many, many weeks later where fancy testing came in and actually allowed us to be able to figure out what the organism was that was causing the infection to be able to better treat it. So tsunami lung was something actually was very common. The other things that we saw, for example, are tetanus. We saw tetanus because the tetanus immunization levels were very low. We saw measles again, and again, you don't want to see measles in this kind of population because you know it can be a big, big problem. And we also saw lots of cases of diarrhea, and certainly, again, it's the issue around water sanitation and having appropriate and good, clean water supplies, which we know that they didn't have before. We actually did a study which was published in the Pre-Hospital Disaster Medicine Journal at 9 weeks after the tsunami, because we were actually looking prospectively to actually see what kind of sort of diagnosis or things that we were actually seeing when people were coming into the emergency. And in fact, 87% were no longer even related to the tsunami. Most of them were related to primary health care, and most people had, because of the conflict, had no access before, so they were coming in with very, very late kind of illnesses and cancers and things like that as well. So it's interesting to sort of think about what the needs are, because often you think about sending a surgical team, but in fact primary health care is actually very, very important to get in there early. And I think that's something that the International Committee is starting to get a better sense of. But at this point in time, I still think that that's something that we have to really work on. So one of the things about I would call a myth, is that I think that we have to be really careful when we do this international response that it's not this group, including myself, that are actually the heroes in these situations. We're just, we try to do our best, but we arrive late. We try to, fill a capacity and fill a gap. But the reality is that the people on the ground and the people who were there during the episode are the ones that I would consider the real heroes. And I'm going to show you a picture of some of my heroes. Aldi's on the left-hand side, Nana's on the right. Nana, they were both my translators actually, and I still keep in touch with them and know them very well now. But Nana actually lost everything, absolutely everything, except for her beautiful son who's sitting beside her. He's now 14. And Aldi was actually the reason that this project has actually sort of come along over time, because he was actually a medical student at the time. And he and I had lots of conversations about the effect of conflict on training and healthcare providers and that sort of thing. And he's the one who actually made me start thinking that maybe we could do something further and do something more than not. So that's Aldi, and I want you to remember him because you're going to see him at the end in a different context, so just remember him. The other thing I just wanted to say is that even after a month after the tsunami, the rescuers were still picking up 1,000 bodies a day. 1,000 bodies a day after a month. So it was really common that even after a month we were seeing bodies and body bags on the side of the road. And one of the things that happened, that is a myth, but one of the things that actually happened was that a lot of people, what happened was there was a decision made that there needs to be mass graves because they were like tens of thousands of bodies, right? Something had to happen and had to happen quickly. So these mass graves were actually built and filled and covered. And the problem with that is that so many families never had closure. They never even got to go try to identify their family members at all. And that was very, very difficult for many people. And the challenge here is that when people die of an earthquake, their bodies aren't going to be contaminated and spreading things very easily. It's very different if you've got an outbreak, like a cholera outbreak or something. That's a very different situation. But people die in a tsunami because of the injuries that they have, not because of an underlying problem. So in this kind of a situation, in fact, dead bodies do not transmit communicable disease very easily. And so the better thing in retrospect would have been actually to have some sort of way of families coming to identify, and then they can do what they need to do with that body at the time. So that is something that actually comes up over and over again, and it keeps happening actually after earthquakes in particular. So after this happens, and this is the disaster response, then what happens? Well, after about 2 to 8 weeks, a lot of the international organizations say, well, you know what, our job's done. We've done what we came here to do. Our mandate's been completed, and they leave. The media tends to leave at this point because they're no longer interesting, because it's just not interesting for the media anymore. So what happens then? Well, for many, the job has actually just begun. And this is the piece that we looked at is, okay, and I remember leaving thinking, I haven't left. I'm coming back. There's a lot more work to be done here. So if we look at the actual disaster cycle, the big star there actually is the disaster or the earthquake or whatever. And then the reconstruction phase, usually depending on who defines it, lasts, say, 3 to 6 months. But then there's that whole really important development kind of phase where you're looking at disaster risk reduction, emergency preparedness. And this is the piece that we thought we would like to do some more work on. So if we think about that development phase, I know some of you have done a lot of work in development. We think about the greater quality of life for humans as one definition, certainly. And there's lots of issues, actually, that we think about when we're talking about development. Certainly sustainability, capacity building, governance, healthcare, education, poverty reduction, gender equity, disaster preparedness, economics, human rights, and the environment. So when we were talking about, well, what do we do and how do we move on from here and what kinds of projects should we be working on, we actually thought about initially starting with the medical school, and that's what we have started to do, and then it's expanding now. But we decided to focus on primary health care, education, disaster preparedness, and really with the concept that primary health care is a way to health equity for many people. The primary health care system in Indonesia is not very strong like it is in many low-income countries, which is actually really too bad because that's the only way really that we know that we can try to at least encourage and have some sort of health equity. So we know that in Aceh, actually, before the tsunami, they only had one doctor per 10,000 population. And we know that 265 of the 283 health centers were either completely destroyed or damaged to the point of being partially functioning. So really significant damage because of that. So what we did then is we said, okay, who's going to be involved in this and how is this going to go forward? So what has happened is actually, if you look at the very bottom, you'll recognize the campus. So McMaster University, Department of Family Medicine, teamed up with the university there, which is called Shakwala University, and the Rotary International. Now, Dr. Shankardas, who's not here this evening, I don't know if any of you know Dr. Kanwal Shankardas, he's a very well-known physician actually in the city. He's got his practice in Dundas. And he is also an avid Rotarian, and he's done a lot of work with the Rotary, doing some amazing projects, actually. And he was really interested in actually being involved. So from the Rotary perspective, he's actually really been the lead on the project from the Rotary perspective. So it's been three universities, and we've actually been working with the vice governor in Aceh. And we had a really interesting meeting with him about a month ago when I was there. I'll tell you a little bit about that in a minute. So what are we doing right now? So the two basic things that we've been working on is really trying to get those primary healthcare students out in the communities, because they were very hospital based and very tertiary care based, and that just doesn't make sense to try to care for that population. So we actually tried to get we're working with the School of Medicine, School of Nursing, and Midwifery, actually, to try to see how can we actually do better training. And in the two areas of curriculum that they've been consistently working on is the primary health care, family medicine, but also this whole concept about disaster risk reduction, emergency preparedness, but focusing on the community. I'll show you some photos of what I mean by that, but that's a very, very different perspective than certainly most medical schools do around the world, and I actually think that they're the only one that I know that's teaching it in the way that they are. So it's an interesting pilot to see sort of how that's all working for them. So where is this happening? So just outside of the city of Banda Aceh, the Rotary has this little complex. It's quite rural. The area around it is quite poor, has virtually no access to care until now. And there's 3 different sort of sites on it. There's a health center, the school, and the orphanage. And so this is where and what they're doing is that this is actually going to be more of the pilot center. This picture here was taken about 2 years ago, so it's actually developed a little bit more. But the left-hand side is the health center, and the right-hand side is the dormitory for the kids. And what they're doing now is that we just had this meeting with the governor, who actually agreed that this clinic would actually be covered by the free health insurance, which is a new thing that actually just happened last year after years of trying to push. We have a colleague at the university who was working in the Ministry of Health, and he pushed the agenda and got it through last year, which is a huge, huge change from whatever happened before. So at this point in time, this is one of the sites specifically for taking some of the students more into the community. Sorry, the question here.
Sorry, is this an area that the tsunami went through?
So this area right here actually is just a little bit inland. So the tsunami didn't. The earthquake certainly did, but not the tsunami water itself. Yeah. So if we think about bringing students into the community, we know that primary health care provides better satisfaction at a lower cost. And we also know, this is actually a photo of some of the boys in the orphanage with some of the teachers. And we also know that that the primary health care, we have better health outcomes. And a doctor by the name of Dr. Barbara Starfield, who was actually American, did a lot of work on this initially in the US, showing that. And in fact, she showed that she did a lot of work around specialist-dominated systems have higher healthcare costs and reduce access by vulnerable populations. So she did a lot of pioneer work on this. And then she expanded her work to go into low-income countries. Unfortunately, she passed away in a swimming pool accident about 2 summers ago. But her work is really pioneer for a lot of this kind of basis of this. So this is actually a picture I took just last month of some of the girls in the orphanage and some of the teachers with my daughter standing on the side there. She's as tall as one of the women who runs the whole program. So in terms of education and research, we're really sort of asking some questions now around how do we focus on community-based education and research partnerships, and we've had lots of discussions and lots of movement around some of that as well. And obviously the issue around sustainability is always a big one, and the Aceh government has actually agreed, the Ministry of Health has actually agreed by the next 18 months to take over the operational costs of the facility, which is great because then we can slowly phase out of that, because right now it's a Rotary Club of Dundas actually helping to fund certainly part of the operational costs right now. So, if we turn around and look at the university campus, it's actually a beautiful campus. They've done a beautiful job in the past 8 years. They've got some really neat clinical teaching centers there, and anatomy lab, and all sorts of really neat areas. But the second part of the partnership is actually really around the disaster risk reduction, emergency preparedness. and to build more resilient communities. And that's a very, very different perspective than what they've ever done before. And I'll just show you some pictures of what that really means. So they're actually taking the students out into the communities to do training on hazard map development. Now, these students had no idea what this was. So they actually take them and they made the students go out to their own communities. And many of them just came into this, either actually were from the city and then they had to have a community outside, or they went back to their community where they originally came from to actually try to ask some questions that they'd never been asked before. You know, thinking about, okay, what are the hazards in this community? Most likely we're going to have another earthquake. What would happen in an earthquake? You know, what's the high point if there was another tsunami? Where's the high point? Which way would we go? How do we actually structure so that we have tsunami evacuation routes? All those kinds of things that they never would think about. What about water points? What are the water sources in the communities, and how in fact what's the likelihood of those getting contaminated, and therefore if it was contaminated, what are the alternate water sources? And just thinking through things much, much broader than they actually have ever thought before. So this is one example. This is just makeup, don't worry. They did a disaster day simulation. These are all students, they're having fun actually. But they did a disaster day simulation as well. And one of the interesting things that happened was one of my colleagues, Dr. Rosaria, who is one of the senior faculties here, she actually had an interesting story. She said that she was 8 months pregnant when the tsunami hit. The water came up to about here at her house, and it was very, very strong. And she tells a story about how she barely could stand up. In fact, she was pulled out. The water was so strong, she kept getting pulled out, pulled down, pulled down. And she felt like she was going to drown. And these 3 men just came out of, she said, nowhere, just picked her up and pulled her to where it was more shallow. And she was still trying to catch her breath. And, you know, she was just like barely hanging in there. And people in the community knew that she was the healthcare worker in the community. They knew who she was. And they looked at her and said, "What do we do now?" She's thinking, I don't know, I'm just a doctor. I don't know what to do. But for her, that was a real tipping point to say, you know what, we actually need to be much like the community leaders, and whoever they are, really need to be trained in this kind of thing. And that was her thinking about, okay, now we should really be thinking about how do we encourage that. So interestingly enough, they had this training, not just the disaster day, but the vulnerability mapping and all that kind of stuff. So they did all these exercises. 4 months later, they had another major earthquake. So they actually had a real experiment where they actually had an earthquake. And then afterwards, she actually interviewed all the students again and said, was that helpful? What worked? What didn't work? And she got some really, really good feedback that, in fact, the same thing. People in the community came to them as leaders and said, what do we do? And they actually had a sense of what the heck they were supposed to say. So it's just an interesting perspective on some of that. Sometimes we go into the actual university and we'll actually do some lectures. This was actually capacity building seminar that we did with the School of Nursing. And this is actually, where's Dr. Basanti? This is actually the Dean of Nursing on the right-hand side. He's coming to visit next month. So anyway, this is a group of nursing faculty. So we were doing some various different faculty development this day. And then this is another example in the community where the students actually went into the community and actually spoke to some of the leaders in the community, again, around the whole issue around resilience and that sort of thing. So these are some of the things that are actually happening. And then the last one I just wanted to show you here was a picture of the students. They actually have this very interesting tabletop community disaster simulation, but it's actually very, very real. So they did this before they actually did their real simulation. And it's just another way of teaching and learning. And there's been some development about, okay, how does this stuff, how can we actually use more modern technology to actually expand this kind of a project and program? So they've talked about everyone in Indonesia has a cell phone. The numbers have increased by 5 times in the past 3 years, significant. So everyone almost has a cell phone. It's pretty incredible. So the question is can we use mobile technology actually to be teaching some of this, to be developing apps so that we can actually look at water point mapping and that sort of thing in the communities actually that will help with disaster risk reduction, as well as a response when a disaster actually happens as well. So this is really what's happening from the current situation in terms of the model that's happening. And I'm going to go to this picture and tell you that 8 years later, after all this time, when I go to Aceh now, we go to coffee shops. And coffee shops is the thing to do. It's the sort of the social thing to do. You go to a coffee shop. And it's interesting because somebody told, I couldn't believe there's a coffee shop on every street corner. They're everywhere. And somebody said to me, do you realize that this is a sign of development? This is an indicator of development. I said, really? Coffee shop? Okay. They said, yep, it has as many coffee shops per capita as Copenhagen does in Denmark. Apparently they're number one. So I thought, okay, when I look at this now, this must be an indicator of development when I think about how far and how long they've come. I wanted to move you just to see this is what it looks like now. The streets are actually pretty good. The traffic depends on the day, but it's relatively structured. And in fact, in the past few years, people are actually wearing helmets on their heads now, which was a huge public health problem because there were so many head injuries and people either being killed or major head injuries in the hospital. So these are really coming along nicely now. So then if we look at where we are from that graph again and think about how can we expand this, certainly the concepts of the environment are going to be really important as we move forward with this training. So I would ask all of you who know more about the environment than I do to think about, is there any way we can work together? We can think about how we can actually expand some of the stuff that we're doing right now with the training that's happening, capacity development right now. This is the Grand Mosque. I didn't show you a picture at the beginning, but after the tsunami, this is the most photographed building in the whole place because the mosque was up. Many people went there for refuge. Everything else around was destroyed. It was pretty incredible to see the story. But this I just took about a month ago now, and it's really built back up, and it's very beautiful. So as I start to close, one thing I want to tell you that Dee Dee, who I told you about earlier, he's doing really well. I saw him last month. He is remarried. He has 2 new children. He's very happy, and he's almost got enough money to buy a new house now. So he's actually really come along and a lovely person. In terms of next steps for this project, certainly the immediate next steps is that we actually have 3 university guests coming next month here to Hamilton for a week. So they're meeting us in Vancouver for some international consultation meetings, and then they're coming here to McMaster. So if anybody's interested in hearing about that or being involved, I have to think of all the social things for them to do too, because I need them to get to Niagara Falls and the CN Tower and stuff. Certainly those are some of the things that we're doing. And then next year in 2014, we're going to be doing a faculty development. They've asked us to come and do some faculty development, specifically, again, around primary healthcare, family medicine, as well as research. They really need some capacity building around research. So those are some of the things that we're going to be working on with them. So if I had to just say a couple of thoughts just to sum up, I'm going to say them fairly quickly. Humanitarian response and the whole issue of humanitarianism is very, very complex. Water is very good. It's essential for life, but it's also very bad and can be. And I can't do my job if I don't have safe, clean water and colleagues to help me to do that, but also to help me understand the more broad meaning of water. And that's either during a disaster or all this development work. So I really value my colleagues who know more than I do because I find I learn so much from them. And to my other colleagues who work in completely different areas, so sometimes it's difficult because we come from such different perspectives that it's hard for us sometimes to work together. But I would argue that all of us should actually really be thinking about how we can work more closely together. And whether we're talking about researchers or think tanks, how can we actually, are there people or other perspectives that we should be pulling into a project like this as a pilot just to see and learn from each other. The last thing I was going to do is, if the Red Cross in Canada asks us always to say, are you prepared here in Canada for disaster? They do recommend that we have a 72-hour kit available in our homes with things like a flashlight with battery, with cans of food, with a manual can opener, with water, with those kinds of things. There's a whole list of things. So if you're not familiar with that, you should actually go to the Canadian Red Cross, I think they call it Emergency Preparedness Kit, and just look that to make sure that you actually have that, because it's actually really important to do. With the ice storm in Quebec, actually in 1998, that was a good example of why we actually needed it. So those are some examples. And then last thought, I have Dr. Rinaldi here. He's not able to say this for himself, but he's asked me to quote this. This picture, actually, you recognize the one on the left is the hospital, the teaching hospital that I told you about. And this is the one on the right is the current status of the hospital. So this is what Dr. Rinaldi said. He's a great colleague now. He's in the Department of Medicine. He's very avant-garde in terms of thinking primary health care. And he's visited McMaster now 2 or 3 times. But I keep teasing him that he's going to be the dean one day. But this is his quote. He says, one of the main points I'd like the general Canadian public to know about international aid and development is something I call community empowerment. In simpler words, the helpers are not the subject and the helped are not the object. Reconstruction and rehabilitation in Aceh has been successfully done because international aid and development perceive Achenese people as a responsibility taker for the future of Aceh. Working together with local people by empowering them to rebuild will result in continuing and unstoppable rebuilding, including capacity development, even after the international aid and development finish their work. One of the ways to deal with the problems is by conducting continuous capacity building, which might take longer than just the physical rebuilding. However, capacity building has long-term benefit, which can be enjoyed for years or even decades after the disaster. Thank you very much.